Welcome to Under the Microscope.
Brought to you by the Right Credentials Network and your host, Dilsa Bailey, a certified medical services professional for over 20 years. Under the Microscope is where we will examine the many layers of the medical services profession using the acronym SCOPE. That's S-C-O-P-E, which stands for S, Services for Onboarding and Maintaining Providers in a Healthcare Organization. C, Credentialing and Privileging Providers to ensure that they are competent and qualified enough to treat patients safely in a healthcare organization. O, Operations and Data Management, utilizing the healthcare organization's resources efficiently and overseeing the security of its data, promoting patient and provider safety. And P, Provider Enrollment, affiliating providers with health plans and government payers so that the providers can get paid appropriately. And E, evaluating and monitoring provider performance to ensure patient safety. As a medical services professional in the healthcare industry, our primary focus is to promote patient safety. Though we do a lot, we can't accomplish this on our own. It takes a village to collaborate. That's why this podcast will also include the contributions of our healthcare partners with the same objectives. So stay tuned to hear from those other stakeholders in the healthcare industry too. Joining us, in addition to medical services professionals, will be experts in risk, legal, revenue cycle, quality, and more. So stay tuned. Keep us under the microscope so we can help expose all the little details of the medical services profession. We want you to remember how valuable you are to the healthcare industry. If you're watching this on YouTube, please subscribe, drop us a like, and hit the bell so you will know whenever we add the latest episodes. And in the meantime, follow us on LinkedIn or reach out to us at info@therightcredentials.com. In each episode, we will discuss a separate topic related to the letter in the acronym of the moment. But we won't be discussing it alone, as I mentioned. Each episode will feature a guest who will share their expertise, providing advice, training, and support wherever possible. So let's get started with the latest episode. And if you like this one, don't forget to subscribe on YouTube and continue to listen to us on your favorite podcast platform.
Welcome back to Under the Microscope. In this episode, we're going to focus on the letter E in the acronym SCOPE. And what does E stand for? Well, it stands for Evaluating and Monitoring Provider Performance to ensure patient safety. You know, those are the key words, ensuring patient safety. And as always, I've invited a guest to walk us through a specific topic or to just help us out, help us understand this specific area related to the letter E. And today's topic is one that sometimes is very challenging for the medical services professional because in order for us to provide that information to the clinical leadership to assess the provider's performance, we have to reach out to our stakeholders, our healthcare partners in the healthcare organization. So one of those individuals or one of those departments that we reach out to is risk. So today we're going to talk about what makes good clinical risk management. What are the practices to make that key to helping us? Because we're usually using risk, and I'll mention a couple other departments that we'll actually use, but today we're focusing on risk. We use quality, compliance, human resources, revenue cycle, and all of the individual clinical departments depending on the type of the organization you're in. And they may have different names because I've come across so many different names for some of the same procedures or the same processes, but every organization is unique. So you'll have to figure out which one of your departments meet this requirement. But today, in today's episode, we're going to take a good look at good clinical risk management practices. And we're going to talk to our subject matter expert, who I'm so happy to see. I hadn't seen her in so many years, Kathleen Pendleton. Yay!
Yay! Yay!
Now, Kathleen is our guest who will be talking about the contributing factors that are available to determine whether a provider should continuously or is continuously fit to be affiliated with your organization. And I know
Hmm.
that's a mouthful, but you want to remember these two words: continuously fit to be a part, because you want to make sure we have the right people in the right place treating our patients
That's right.
safely. So,
That's right.
Kathleen, welcome to Under the Microscope. I'm so glad
Thank
to
you.
see you again. So glad we're still in the healthcare game. But
We are.
before I jump into all the questions, because I know everybody is waiting with bated breath to find out how this all works together, can you tell us about your experience, period, and especially with clinical risk management?
Oh, sure. Okay. Thank you for inviting me today. It's awesome to be here. So, I have worked in clinical risk for, I hate to say it, many years. I'm not going to say how many. Um, I'm certified in clinical risk, patient safety, and healthcare quality. So I currently work in patient safety, but I do maintain my risk certification. And I still, as you know, because I post on LinkedIn a lot, I still keep my hand in clinical risk management. Did it for a long time and had some really great leaders like you that I learned a lot of information from. So I love being here and I'm happy to be part of your process.
Thank you. I'm so happy to have you. I'm trying to promote collaboration between all our healthcare partners. We all
Hmm.
have to work together to make sure our patients remain safe.
That's right.
Yeah. So I'm going to jump into the questions. Okay.
Sure. Yeah.
So why is the provider credentialing process good clinical risk management?
Well, that's where risk management really starts. You want to make sure the providers, and this isn't just for physicians, this is also for advanced practice providers. You want to make sure that these folks are who they say they are, what their medical malpractice background looks like, and just generally, are they going to fit into your culture and your safety culture? So when you're evaluating that practitioner, and I'm going to say practitioner and or physician, you want to make sure that they have the background that you're looking for. I'll give you an example. There's been a lot of stuff in the media recently about physicians that, or people that represented themselves as physicians that really weren't,
Right.
or they appear in hospitals and say, I'm Dr. So and so, and everybody just takes them at their word, and they're touching people and trying to take care of people, and they're not physicians or advanced practice practitioners. So I think looking at that process, you want to make sure, yes, this person is legitimate. They've had the background they have the education they say they have, etc. And that's really where your risk management starts. Because, if you have an adverse event, it usually does involve a practitioner. So when all that comes out in a litigation, and everything comes out in litigation except for the peer review part, which is protected. So they're going to look at, did this person really go to XYZ medical school? Did they do this residency? And that's really incumbent on the medical staff team and professionals to validate, yes, this person is legitimate. What does their background look like? What does their medical malpractice background look like? Are there any red flags here? And I really appreciate that. And I was taught like that's really where your clinical risk starts is with the credentialing process.
Yeah, I agree. I mean, if the credentialing department did not exist or the credentialing process did not exist, our patients would be in dire trouble. I
Oh
mean,
my God.
yes,
They would be in a
and I'm
lot of
like you. I
trouble.
see all of that good stuff on the news and wonder, how did they get in there and how did they walk around like they were physicians and
Right.
it's like what we do is very valuable and
Yes.
it is the gate. We are the gatekeepers. I know that's the motto
Yes.
for the NAMS organization, but yes, we're definitely the gatekeepers. So the next question I have for you is, what can we do if we already start processing a provider and we realize he's or she is not a fit?
That's a time when you escalate it up the chain of command
Hmm.
and say, hey, chief medical officer, vice president of medical affairs, and that's usually who's involved in that process, or take it to the medical exec committee and say, I have some concerns about this, or our team has some concerns about this, and these are what the concerns are. And physicians, the med exec team is made up of physicians. They want to know just the facts, and they want to know it very clearly and concisely. So you can't go in there and be like, well, I have a dissertation about why this person isn't a good fit. You need to say, this is why, bullet point, bullet point, bullet point. This is why this person's not a good fit. And I think it's scary to do that because it can be intimidating, an intimidating atmosphere. But hopefully, if there's a collaboration, a good collaboration, you feel okay going in there and saying, I have concerns. They trust that team enough to say, okay, what are the concerns? Because that's really where you want to catch it, right? Before the person starts. Because once the person signs their contract, and you know this, and they start, it's much harder to get that person out of the organization because of the way the laws and rules and regs are set up, and you have to have the due process. So it's much easier to do it in the front and say, hey, this person may not be a good fit, and this is why. And then if they, send it through or say we need to talk to the attorneys or whatever, and they get vetted to come in, then you've done your due diligence and you've done what you can.
Awesome. Yeah, that's a
Yep.
great way to explain what to do, because I know,
Yep.
especially working in hospitals, you can get very intimidated because most of the time, a lot of the time, you get face to face with these people who
That's right.
don't want you to block them or block the person that they're trying to come in the door, and they
That's right.
will confront you.
Hmm.
But you have
Yes.
to, follow the guidelines and follow your gut too.
And that's also, oh, I'm sorry, interrupted you. Go ahead.
No,
I'm
no,
sorry.
you go ahead.
I was going to say that's also a time you can bring risk in and say, I've taken this up to the physician, chain of command, or medical exec team, and I want to let you know as well. And I will tell you that there is an avenue to work with the attorneys
Okay.
and say, hey, there's some concerns about this physician, and they may be able to opine, not from the corporate standpoint, but from the medical malpractice standpoint, and say, hey, we've seen a case like this before, or we've seen a similar situation. And you can take that as well as part of your case as to why that may not be a good fit.
Okay. Great advice. Great advice, Kathleen. Now, here's a good question for you. I know some MSP, some people in my profession may be new and they may be listening to this just to get some information. But then there are some who may be in an organization that does not require this because of the organization type. But tell us about the National Practitioner Data Bank.
Hmm.
Yeah.
It's a
Um,
good tool.
it's a great tool. And
It's a
how,
great tool.
yeah. So, how is that credentialing? How is that used in the credentialing process for risk management?
So I will say I have kind of limited experience with this. You probably have much more experience, but I do know that that is part of the credentialing process. And it does have information about the physicians that has to be reported, usually codified, like in a law. And it will say if you have a medical malpractice lawsuit over X number of dollars, it has to be reported to the National Practitioner Data Bank. And that, I wouldn't say it's by law, it's like by regulation with the medical boards.
Hmm.
So, as part of credentialing process, the credentialing professionals will pull that information and say, okay, this practitioner may have, would be specifically physician, may have X number of lawsuits. And then they can ask that physician, can you give us some more information about this?
Right.
Now, sometimes with litigation, people get angry and they sue. But me, if you see a pattern and you start seeing a pattern over different states too, like you see
Mm-hmm.
some in Florida and you see some in Alabama and you see some in New York, and they're similar, you may have a pattern there of practice behaviors you may not want in your organization,
Right. Yeah.
especially in today's litigation environment.
Yeah. So it is a great red flag for especially the medical malpractice cases. Um, and that was the other thing I was going to ask is what if a provider has med malpractice? But you just described what would be a concern. It's like, what are
Hmm.
those patterns? Because are they continuously operating on the wrong site?
Right,
Do they have,
right.
maybe they have a whole bunch of little um, claims that were
That's
settled,
right.
but why do they have so many?
That's right. That's exactly right.
So those are the kinds of things that affect credentialing, and that's when also risk needs to take a look at that. Because I know in some
Hmm.
organizations, risk is involved with the malpractice because the organization provides like an
That's right.
umbrella insurance policy, and
Hmm.
they bring risk in to look at some of that data in order to make sure that there's no pattern that's exceptional that says we don't want to cover this person because we're going to end up putting out all this cash for that.
That's right. That's exactly right.
So here's a question for you too,
Sure.
and I think this covers credentialing and risk. How about the practitioners provide of their private lives, like
Oh, yes.
divorces, traffic tickets,
Yep.
DUIs? Should we be Googling these practitioners? How
Yes.
does that,
Yes.
are we
So I'm going to
getting
give
too
you,
invasive?
no, you're not. And I'm going to give you an example. And this is a public example, and I'm not going to name names, but this is a recent example. And then I'm going to give you another one. So the first example, there was a case out of Texas where a physician was tampering with IV bags in an ambulatory surgery center. So that turned into a criminal case and a medical malpractice case because there were lots of patients harmed. A patient died. So there was a lot of medical practice around that, but there were also some criminal issues. So it came out with this physician that he had several criminal issues, although they were small, but like a divorce in a neighbor situation and things like that came out that should have been red flags to the credentialing folks.
Mm-hmm.
But for whatever reason, either they didn't know or maybe they knew and thought, well, it's not really that big of a deal. But then all of that turned into this tampering case with the IV bags because he tampered the IV bags because he was angry at the facility.
Oh, wow. That part I didn't know.
Right.
Wow.
He was angry because he was being investigated for some standard of care issues, and he got upset at being investigated, and this was like a retaliation. So, and this is all public information that's out there in the media, not mentioning names. That is a real case. Another case that I personally was involved in is we had actually, when you and I worked together, we had a physician who had a very active social media presence, and some of it was not very savory. And that started coming out of medical malpractice cases because at that time there were limited privacy settings on social media.
Yeah.
So all of this information was public and anybody could see it. So I always teach when I teach like new resident orientation or new nursing orientation, all your social media is discoverable. Every bit of it. Doesn't matter if you have private, you say that you only have 5 followers. It doesn't matter. It is all public information. LinkedIn, Instagram, Snapchat, TikTok, Facebook, all of that is discoverable. So if there are pictures of practitioners drinking, smoking marijuana, um, doing other things, wearing inappropriate clothing. People judge that and they're going to say, and I saw this happen with my eyes and my ears, okay, we have a picture of you drinking an alcoholic, what seems to be an alcoholic beverage. Are you drunk right now? Were you drunk the day this event occurred? Do you have a drinking problem? Do you drink and drive? Do you have a DUI? Should we
Hmm.
do a background check on you? This all was in a deposition. So people have to understand that physicians and nurses are held to a higher standard. So when people see this, they're going to judge it. And the plaintiff's attorneys have a field day with it. So, in my opinion, yes, I do think you need to Google people, look at social media, and we had to have our attorneys tell the physicians you need to pull back your social media if you have inappropriate things on there or what other people may deem to be inappropriate. So, you know, and all of that is discoverable. Text messages are discoverable. All of that is discoverable information in a lawsuit, whether it's a divorce, a lawsuit with a neighbor or a friend or a family member or a medical malpractice lawsuit.
Yep, and it never goes away.
Never goes
Never
away.
goes away.
Snapchat does not go away. People think, oh, I'll do a Snapchat and it disappears in a minute or whatever. No, it doesn't. They have records of all of that. Yep,
Wow. Maybe the practitioner should be listening to this too, right?
for sure. But it's good to know because a lot of people don't realize, like they get in a car wreck and they sue, right?
Hmm.
And they think, oh, well, my social media is mine. It's private. No, it's not private. No, neither yours or the person that hit you. So it's not just medical malpractice, it's really for anybody.
That's true. Wow.
Yeah,
We're all, open to the public.
that's right.
Every last one of us,
Terrifying, actually.
yesterday I was
That's
asked
a
if I
whole nother
wanted to,
call, though, right? That's a whole nother session.
yeah, yesterday I was asked if I wanted to apply for a credit card in a store I was in. And I said, no, I don't want to give anybody else any more information about me.
Right.
It's like, that's
Agree.
enough. I don't need to give out any more.
That's right.
You know, and I mentioned before, it's like, are we getting invasive? But there are concerns these days, and I know some concerns out there about how much we should know about a practitioner's mental health and their current status with substance abuse.
Right.
I know there's some application changes going on where we can't ask, can only ask so much now. You can only
That's
ask
right.
about their current, not their past, I think. I need to go back and review that piece, but I know that change is coming down the pike in a lot of different
Hmm.
areas. Does that fall under what you would consider a clinical risk management concern? Because it
Yes, it
concerns me a
does.
bit. Yeah.
Yeah, it does. And so I know there's a lot of physicians out there, especially the younger physicians, they're really championing not discriminating against people that have mental illness. And there's one physician in particular, he's a resident right now, and he's got a very active social media where he says, I had mental illness and I'm becoming a physician and I'm, working through that and it's perfectly fine. And I definitely see that. I totally see that. The problem is, unfortunately, when you get into a medical malpractice lawsuit, all of not that doesn't become discoverable because that's HIPAA protected information. But the plaintiff's attorneys will fight to get that information, and they can pull like DUI and things like that. And I will say, in this, and this, everywhere you go in Atlanta smells like marijuana. I mean, literally everywhere you go, whether you go to a restaurant or you're driving down the street or whatever, people are smoking weed like everywhere you go, and it's become much more normalized. But then you have to ask the question, do you want your physician to be impaired in some way when they're practicing medicine, and is that okay? And I think that will probably modify in the next few years as we work through all those issues with the more relaxed requirements of what we consider to be drug use. But and it's become more normalized. But I think also perception is often people's reality. So I do think that that comes into play. If you have, let's say, a team member of the facility that's questioning the physician or APP's state of mind, and they refer them for drug testing, let's say that they decide, okay, we're going to test this person for drugs, and they turn out to be positive. A lot of times they will send the physician for treatment. That they'll send nurses for treatment to try to get them to a place where they can come back into the organization. And that's a total sea change. It used to be like they were gone, but now it's like we're going to send you for treatment and then see how you do and then invite you to come back and we'll work with you. So I think that's changing, but also that perception too is out there, like, do you really want your physician, because sometimes people think, well, they smoke marijuana, they're fine. But if they have 4 margaritas, they're not fine. But then really, what's the difference? So you're still taking something into your body that's modifying your mindset. So, but I think all that's going to change the next few years. I really do.
Yeah. I can see it from both sides. I really
Yep.
can. It's just that when I also read all the cases, that when you come in when you're credentialing and you see all the cases and you're going like, how did this one get through?
Right.
So
That's right.
there's good side and the bad side. But it all boils down to patient safety. So we got to figure
It
out
does.
how to
And
make sure that balances out somehow.
yeah. And the way I always look at it, and you and I dealt with this when we worked together, we had some folks that were doing TV shows.
Hmm.
You may recall that. And, there was a lot of chatter about, like, how is that going to affect this person's job? And is it going to affect their job? And how is that going to look? And as I understand and I remember, it didn't end up great. And there was a lot of, like, what do we do? So I think we're starting to get more into uncharted territory with media, social media. There's a lot of physicians that have very prominent social media accounts. And me, the first thing I do when I see, especially one particular physician comes into mind, I always think, this is going to be gold to a plaintiff's attorney. That's what I'm always thinking in my mind, because they're
Yeah.
going to look at this and be like, well, were you busy making a TikTok or were you taking care of your patients? And when you were taking care of your patients, were you thinking about making a TikTok? And when you're driving your $100,000 car, are you stealing money from your patients? This is all
Right.
the stuff I'm thinking in my mind, right?
And are
And
you
sometimes I
exposing the
think,
patient's
yeah,
information? You know?
right. Exactly. Exactly. Are you exposing their information? Are you giving medical advice that you, as a ex-physician, shouldn't be giving because it's about another subject?
Yep.
So I really think that that's going to be a new thing to deal with in medical malpractice. Plaintiff attorneys will love it, though. I'm going to tell you.
Yeah, they're gonna have a field day.
Yeah, and I think that's something credentialing should ask now, actually,
Yeah.
is, do you have a social media presence, and what is your Instagram? What is your Facebook? Do you write books? Do you have a blog? I think we probably need to know all that information and not be surprised.
Yeah. I think you're absolutely right about that. Yeah. Very
Yes.
good advice. Yeah. I agree with that. Now, let's see. Next question is,
Mhm.
can you explain how quality metrics specific to the practitioner, how that's used in the credentialing process from the clinical risk perspective?
Sure. That's really like our clinical peer review folks. But what they do is they look at what's called OPPE and FPPE. So they're looking at like a snapshot of their quality and then their continuing quality metrics. And if they start seeing anything going wrong, so to speak, and I don't want to say wrong in a bad way, but let's say, like you said earlier, let's say you have a surgeon who had no wrong site procedures for 3 years and all of a sudden they have four. They would bring that up to the medical exec committee probably and say, hey, we have something going on here you may want to take a look at. So
Right.
they have certain metrics they look at. We have our incident reporting system that's for risk. It has any adverse events in there, anything that's out of the ordinary that happens for patients
Okay.
that we can look at from risk. And I used to bring it up to my supervisors and say, hey, I'm seeing a pattern here. Let's dig into this a little bit more. Is it the same physician every time? Is it the same team? Is it the same type of patient population? What's going on? Like, let's say you see a medication error and you're seeing the same one over and over, is that a pattern? So that type of thing. So there's different ways you can find that information, but primarily it's through that OPPE and FPPE process. Practice evaluation is what it's called.
Okay.
Yes, ma'am.
Yeah. And that's usually mostly in a hospital setting.
Yes, ma'am, it is.
Okay.
Yeah.
All right. So you mentioned some of the concerns that would be raised under the OPPE and FPPE.
Mhm.
Um, what do you think is, well, I think you probably answered that question too. It's because you mentioned that this could be based on the frequency of the concern. And also, I was wondering the severity level, or would that be what would trigger the first, the frequency or the severity? And I guess probably both would be triggers.
Both. Yeah, both. We're very outcome driven in healthcare and very severity driven. So we have a tendency, this is where my just culture stuff comes in, but we have a tendency to overlook the events where there's no harm. So that's your frequency. So if you're seeing these events, and even if there's no harm, and when there is harm, it's the same behaviors. It's just you had a different outcome. So I think we as healthcare could get better at evaluating those no harm events instead of just looking at the events where harm occurred.
Wow. Yeah. And you mentioned the continued behavior. That's,
Mhm.
yeah,
Yes.
definitely
It's the
need to
same
look at that
behavior.
same behavior. Yeah.
That's right.
Yeah.
That's right.
Because we've both seen that.
Yes, we have. Yes, we have.
Oh, yes.
Yes.
Okay. So, do you guys get the patient complaints in risk management as well? Do you come across those, or how are they considered, as
I
part of
used to.
the practice
Yeah.
evaluation? Yeah.
Yes, so I used to have to give those to our credentialing team. So every quarter they would send me a list of physicians and I would have to look in our grievance log and say, okay, I'm making this up. We've had 5 complaints against Dr. A and 4 complaints with Dr. B. And then I would send that. And if they wanted more information, they would come back and say, okay, can you tell me what types of complaints these were? Were they, from patients, from family members? Was it substantiated? Like that kind of stuff. So, and if it went to peer review, I would just tell them, I referred this to peer review and I'm not privy to that. So I would just tell them, this was referred to peer review. But they were really looking, in my opinion, for volume. So are we getting the same complaints for the same practitioners? And then that information, like every quarter, I would give to the credentialing folks.
Okay. Wow. Well, this has been very interesting, Kathleen. Thank you so
Yes,
much. Very
ma'am.
informative, very
Love it.
informative. I know this is going to help a lot of people. And before I end this, though, I want to ask your question of what's your contact information? How can
Oh,
people reach
sure.
out to you to
Okay.
get more information or to ask you questions or to get your help?
My email, people can email me. I'm happy to help, happy to talk. Dilsa, you can help too. So I'm happy to help as needed.
And you're also on
Yes, ma'am.
LinkedIn. You know, we're
I
very
am on
active
LinkedIn.
on LinkedIn.
I
Yes.
am on LinkedIn, and you can contact me there anytime. You can email me through LinkedIn.
Awesome. Thank you so much, Kathleen. And I want to
Yes, ma'am.
thank the listeners for listening in and listening to this valuable
Love it.
information. You know, we love to get your feedback, hear if there's anything else you'd like to know, because I'd love to have you back again, Kathleen. I'm sure I
Oh,
could
yeah,
pick
I'd
your
love to
brain
come
a
back.
lot more. And as usual, folks, if you're listening or if you're watching us on YouTube, please hit the subscribe button, hit the like button, hit the bell so you can hear about us again. And please share these podcasts with other medical services professionals and the other stakeholders in your healthcare organization. People like Kathleen, who can be very helpful. And you guys need to collaborate with each other and collaborate with your healthcare partners because I want
Absolutely.
everybody to remember how valuable the medical services profession is and how valuable we all are when it comes to patient safety. Remember, the
That's right.
bottom line is patient safety. So,
That's right.
Kathleen, thank you again for joining us and covering so many layers of the medical services profession. And I want
Ma'am.
the listeners, please have a great day or a great evening, whatever time frame you're listening to this. Have fun listening to it. Come back and visit us again and share it with everybody in your hospital or your healthcare organization. Share it with medical services professionals so we can all help each other learn and grow. Thank you.
If you like this one, don't forget to subscribe on YouTube and continue to listen to us on your favorite podcast platform.